Slides okay?
Yeah.
We
Okay.
can share and everything is okay.
Good. So I will wait a few minutes until you guys tell me to go ahead, and then we'll get started.
Yes. I propose wait some minutes, yes, and we'll start. And we complete our conversation with Dr. Tompkins. 2 minutes, okay?
Sounds great.
So, Dr. Tompkins, is it okay? I checked today, yes, and sent you some proposition. And you answer me about possible changes in our schedule. Is it okay?
Yes. And if we do one of those lectures that Adam sent to you, then I think we'll just do it at 7 o'clock Oklahoma-City time next Thursday, as usual.
Thursday is bad time for me. Next Thursday is bad time for me because I will be. No, I need have professional trip for next Thursday.
Okay. Well, Adam,
but I can ask somebody from somebody. I mean, my colleagues. And somebody could be participate instead of me.
Okay. Adam, is Friday? Are you available on Friday, Adam?
Yeah, that's fine.
All right.
Yeah.
So Maria, do you want to make it Friday next week?
Yes, it will be good.
Okay.
For me.
And I'm awake. I don't know what I've talked to. I'm an early riser, so anytime is fine.
Okay. So Maria, do you want us to start at 7 a.m. or 8 a.m. next Friday?
7 a.m. You mean like every time at 3 p.m. according in Ukraine, yeah?
Correct.
Okay. It's good.
All right. Okay. Do you have your students logged in?
It's like there's a few.
Are we still waiting, Maria? For
Not we can start.
Yes,
Okay.
Okay. Well, I'll go ahead and get started then. I do want to thank you for letting me participate and give this lecture. Thank you to Dr. Tompkins. Thank you, Maria. I was asked to talk about sepsis and septic shock. My name, Adam Pszebinda. You probably can see that name is Polish. My dad is Polish, and he grew up in Kalisz in Poland, and then came to the U.S. In the early 1980s. So I was born here, but obviously a big connection to Poland. And so I empathize with you, and I wish you all the best in these very difficult times. So anyway, with that statement, let's talk a little bit about medicine, sepsis and septic shock. Let's see here. The agenda today, so we'll have a few things to go over. So we'll look at the epidemiology of sepsis. And it is, a kind of a funny story with all of the changing diagnostic criteria for sepsis and a lot of controversy in sepsis, which we'll touch a little bit on. We will go over a basic overview of pathophysiological changes and then management practices. It's too big of a topic to do all of them, but we'll look at a few selected guidelines. We'll look at their limitations and talk a little bit about the history of kind of guidelines in sepsis and septic shock. A few general comments about infection. So as we all know, it's kind of difficult to have a precise and clinically useful definition of infection. And there can be differences between contamination or colonization or infection. People who are suspected of having an infection may oftentimes not have positive cultures. And many people will develop infections, but it's well known that you know, you take 10 people and they have a pneumonia, and some of them will do just fine, and some of them will decline and develop this syndrome, the sepsis syndrome, which is characterized where the illness is characterized as much by the host response as by the infection itself. So the dysregulated host response to the infection is as big or more of a problem than the infection itself. Briefly, the 4 categories of shock and review for medical students. So we have distributive, hypovolemic, cardiogenic, and obstructive shock. And in the medical ICU, distributive shock is the most common type of shock. And we're focusing in on mainly septic and systemic inflammatory response syndrome, but maybe septic shock, okay? But there are other kinds of shock, of course, and when we see a patient with undifferentiated shock in the ICU, we have, you know, protocols where we try and figure out which type is going on, and usually we're between septic shock and cardiogenic shock, which physical exam, point of care ultrasound, these things are very helpful in determining which one is ongoing. So back to sepsis. What is sepsis? So in simple terms, sepsis is the life-threatening condition that arises when the body's response to the infection is so maladaptive that it injures its own tissues and its own organs. And the precise definition from the most recent international consensus definitions, sepsis 3, is sepsis is defined as a life-threatening organ dysfunction that is caused by a dysregulated host response to infection. The factors involved include the infection itself, the dysregulated response, and the organ dysfunction. And when you have florid sepsis, it is very obvious. You can see it, you can say, okay, this I know, this is sepsis, this patient is septic. But diagnosing it, especially early on, can be a little bit tricky because it is sometimes hard to prove that there is an infection. There can be difficulty in measuring the dysregulation of the body's response, and organ function is difficult to monitor. And this has been challenging, forever. And the changing definitions have tried to make it a little bit more objective over time. A little bit about the scope of the problem, and I have some data from the US and Europe, and the numbers specifically are probably not as important, just that, as we all know, there's a lot of people that are affected by this. So in the US, there's estimates that maybe 1.5 million or so patients are diagnosed with sepsis annually. And in the hospital, of the patients that die, 1 in 3 approximately is diagnosed with sepsis. And in Europe, I found this estimate of maybe 3.5 million. And again, maybe 750,000 of them do not survive. Again, these numbers are, absolute numbers are probably not as important, just the scope of the problem, that it is very common, and obviously we all encounter it in the intensive care unit on a daily basis, okay? Globally, if you look at meta-analyses of mortality for sepsis, from the time period of 1979 to 2015, there is estimates that mortality is around 21%. And more recently, so if you get rid of the earlier data chunk there and you go to 2003 to 2015, mortality seems to be a little bit lower at 17% for sepsis. But when you get more severe organ dysfunction and shock, of course, the mortality increases 30 to 50% plus. And for each additional organ failure you develop, your mortality goes up. Now, I speak about severe sepsis. That is a term that is no longer in favor, no longer recommended for use by the most recent guidelines. However, at least in the United States, we are stuck with it because of the intricacies of how our payment systems work. And in fact, Medicare, which is our government agency that kind of mandates some quality measures and payment measures, requires us to still use this term. So it is a very common thing in the US to still say sepsis, severe sepsis, and septic shock, even though the national, international guidelines recommend these days we do not use the term severe sepsis. So a little bit of background. Now, I did mention that mortality seems to be declining, but we'll get into the data a little bit more and say, why is that? Or are we really doing better or not? So the entity of severe sepsis, which can be thought of as some organ dysfunction with infection with sepsis, but not quite shock, okay? Probably the best way to look at this mortality data is to look at randomized controlled trials and look at the usual care arm. So in the randomized controlled trials for sepsis, there would be some intervention, one arm, and then the usual care arm in the other. And if you look at the mortality there over time, the mortality from the early 90s all the way down to 2009 is decreasing somewhere from 30 to 40% down to 20 to 30%. So there is a decrease here. And the fact that there are different lines is because there are slightly different criteria for sepsis. And so again, that's not as important, except that the trend is for down over time. So probably there is some improvement if you look at more strict randomized controlled trials. There is some improvement in mortality over time. There is, however, also this phenomenon of a bias in the incidence and the mortality. So I'll say the conclusion first is, the conclusion is that because we recognize more sepsis cases, we are including healthier patients. And so that makes the numbers look better. So from the top, there is definitely an increased awareness of sepsis. And this is from, the Surviving Sepsis campaign, as well as a lot of national press coverage, actually, at least in the United States. There have been many well-publicized cases of people dying from infection. And it has actually even generated governmental responses. In some states, the medical care is governed by law that people have to get a certain amount of fluids if there's concern for sepsis. It is surprising how aggressive that is. So because of all these things, we have very high awareness of sepsis and very aggressive screening measures. So when patients come to the ER, they are all screened for sepsis. And because there are vague definitions and changing definitions, many people are diagnosed with sepsis. And at least in the United States, there are some financial and performance incentives for diagnosing sepsis. And to explain that better, so all our hospitals are judged based on outcomes. So we have things like standardized mortality ratios, where governing bodies will look at our hospital performance and say, well, based on your population mix, we expect that your mortality rate should be such and such. If you have somebody that meets the criteria for sepsis and you diagnose sepsis, you are expected to have fewer people survive and your numbers look a little bit better. And so, as cynical as that sounds, there is a impetus actually to diagnose more sepsis. And financially, there is an increased amount of reimbursement related to septic shock and severe sepsis. So even though, we certainly do our best to ignore all of this, and we maintain very high ethical standards, systematically, there are these incentives that lead partially to increased diagnosis. And the last part here is everybody now makes sure that if there is a possibility that they code for sepsis, and that is, again, I think tied back to this part here. So this is the cynical me speaking, but this is reality. So this leads to an increased number of sepsis patients. But as you can imagine, we're mainly adding patients that otherwise we wouldn't have said are septic. And so these are maybe the less sick septic patients. And so we have overall an increase in the denominator and less sepsis mortality over time. So this is a well-established phenomenon. And you can see a little bit here. It's demonstrated somewhat in this slide. So I'll spend a little bit of time explaining what's happening here. So we have two panels, panel A and panel B. And what we're looking at is the comparison of what physicians are coding in terms of sepsis and infections and organ failures, and what an electronic health record is able to abstract from the numbers that are included. So you can say, so we're comparing the computer analysis of the data, the patient data, compared to what the physicians are documenting over time. And there's two ways to look at it. So first, the green and the red here. This is the physician and coding data, and the green is the implicit sepsis code. So if I write someone has an infection and I write someone has, acute kidney injury, then over time, you can see that from 2009 to 2014, more and more people are writing stuff that would trigger sepsis. Similarly, the red one here is if I actually write sepsis in the chart. And so over 2009 to 2014, there's increase, and on average, the increase is 10% per year. So the point I'm trying to make of this slide is that the physician documentation shows an increase of between 7% per year and 10% per year, okay? And this is in sepsis incidence, the diagnosis of sepsis. Now, if you compare that to the computer analysis of the same data without looking at what the physician is documenting, there's a little bit of a different story. So by a more objective criteria, the incidence is going up by somewhere between 0.5% per year and 3.5% per year. So it's clear that while there is an increase in sepsis over time, it is much less than kind of how we document. So this is more evidence that these biases exist. Okay? The second slide looks at mortality over time. And the same thing here, where we compare physician coding to a computer analysis of the data. And so we look at those same patients and we look at their short-term mortality. And the red and the green lines represent the physician coding mortality. And they show that, we should pat ourselves on the back because we are doing a good job. We are decreasing mortality on average between 3.5% and 4.5% per year. But if you compare that to the computer analysis of the data, these are the purple and blue lines, you can see that we are only decreasing mortality by maybe 1% per year. Again, emphasizing that we are capturing more patients and increasing the number of healthy patients that are included in our analysis. And so we are probably exaggerating our effect on sepsis mortality. Okay. So some general comments about sepsis. It is common. The cost of care is very high. The mortality is probably decreasing over time, but some of those improvements are misleading because of increasing documentation and increasing the denominator. All right, so the definitions I've mentioned are a little bit vague and they have changed over time. And the history goes back a long time, but really 1991 was the first consensus conference for developing a well-accepted definition. And at the time, there was a view, a conceptual framework that sepsis results from the systemic inflammatory response syndrome. So the body's inflammatory response to an infection. And they also describe the term severe sepsis as having sepsis also with an organ dysfunction. And then, so sepsis was defined as the inflammatory response to an infection, and then more severely, if there was organ dysfunction, it was called severe sepsis. And if there was hypotension, despite getting fluids, this was termed septic shock. In 2001, the task forces reconvened, and they commented that there are some limitations, and primarily it was because we were probably diagnosing too many people with sepsis that may not have sepsis. But they could not think of any good alternatives, and so they kind of left it alone. From 2014 to 2016, there was another effort, and they came up with probably a better definition, which is this third international consensus for the definitions of sepsis and septic shock. And so this is sepsis 3, which is the current definition that we use. So historically, we viewed severe sepsis as a step from sepsis to severe sepsis to septic shock. And septic shock is the end state where we see these patients that are very, very ill, and they're going to require vasopressors to maintain an adequate circulation. Okay? I mentioned the systemic inflammatory response syndrome, and the kind of history behind it is there was an agreement that there needs to be a way to early diagnose these patients, and they came up with this systemic inflammatory response syndrome criteria. And the idea is that this was an exaggerated defense to some noxious stressor. And importantly, this can happen not just from infection, but also from trauma, from surgery, from pancreatitis. And I'll share the criteria here. So the SIRS criteria include temperature, so either hyper or hypothermia, heart rate elevation more than 90, respiratory rate more than 20, or a PaCO2 less than 32, so hyperventilation. And then the parameters here for white blood cell count as are shown on your screen. And you had to meet 2 or more of those things. And then you had to have a definite or probable infection. And as I'm sure you all have known, the docs that have been practicing for a while, this is a very annoying criteria, because if I go climb the stairs, then I meet the criteria for heart rate and respiratory rate. And if I have a cough, then by the time I get to my office, I have sepsis. So I'm exaggerating here, but the criteria are very broad and they do a good job of capturing septic patients, but they also capture a lot of patients that are probably not that ill. So the specificity is very poor, and this has been a constant source of criticism. The new definitions are better, although in the United States, we still struggle, as I mentioned, because the governmental agencies require us to still use this. So anyway, continuing. So over time, it was recognized that a lot of these limitations, there's an excessive focus on inflammation and this SIRS criteria. Everybody recognized that this is not a very good criteria, but it was what we had at the time. Okay? So there's some collateral damage to identifying septic patients, and we're probably giving too much fluids to other people, but you know, okay. So the updated categories in sepsis 3, sepsis is defined as an infection plus an organ dysfunction, and they want it to be more specific in terms of how we identify organ dysfunction, and the SOFA score is what is used then, and an increase of SOFA score of 2 or more from the baseline, which is assumed to be 0 if you don't know otherwise, is used to diagnose organ dysfunction. And we'll go over that in a slide or two later. Septic shock is defined as it has been before, sepsis plus shock. And then severe sepsis is removed. And the hospital mortality for sepsis using this definition is around 10%. So you're capturing sick people. The SOFA score, which is the sequential organ failure assessment score, several organ systems are scored on from 0 to 4. And if you do not know the baseline, it is assumed to be 0 or healthy. Okay. And the organ systems include respiratory, coagulation, liver, cardiovascular, central nervous system, and renal. And the chart here kind of shows that. So under the respiratory system, we look at the PaO2 to FiO2 ratio, so you need an arterial blood gas. For the coagulation system, you look at platelets. For the liver, you look at bilirubin. For the cardiovascular, you look at mean arterial pressure. For the central nervous system, you look at the Glasgow Coma Scale, kind of levels of consciousness. And then for the kidneys, you look at the creatinine and the urine output. And the cutoffs, of course, are not important to measure or to memorize. These are things that we always look up. And the electronic medical record can calculate many of these things for us. If you input like the Glasgow Coma Scale, etc. So, okay, so the higher this score, the higher the risk of mortality. But keep in mind, this was initially designed as a research tool, and it is valid for populations, but it is, of course, not valid for an individual patient. So there are many illness severity grading scores, and we talk about this on the ICU all the time. Even though, you know, certain patients' numbers may predict 90–92% mortality, that really doesn't mean that's their expected outcome. It means a population of patients that look like them would have this, you know, on average outcome. So we have to be careful in how we use it. But despite those limitations, it is based on data that is easily available, and it is standardized. So we have a similar language. If I talked to someone in Ukraine or if I talked to someone in New York, then we have a similar kind of language. It does provide a good prediction of mortality, and changes over time, you know, do reflect the severity of illness over time. As I said before, we should probably not use SOFA score in isolation, and it is not a good screening tool. And really, we don't have a good screening tool anymore. There are many attempts. We used to use SIRS criteria, systemic inflammatory response syndrome criteria. But as I mentioned before, this captures a lot of patients that probably do not have sepsis. And it's still an open question how to best screen for these patients. I will say that a lot of places still use those criteria, and that's again, for us, mandated by payment systems, but the international guidance is generally not as supportive of that practice. Okay, so septic shock, this is the subset that occurs when there is circulatory and cellular and metabolic abnormalities that are so significant that they increase mortality. And we define it by persistent hypotension after giving fluids that requires vasopressors to maintain mean arterial pressure more than 65 and a serum lactic of more than 2. And this subset of patients has a hospital mortality that is more than 40%. And these are the people that, you know, they'll all come to the ICU and you can clearly say these people are septic. I touched a little bit about screening before, but what came out of this 2016 sepsis definition was the promotion of a triage tool. And there was some confusion about this tool initially, because I think people thought they should use it for screening, and you should not use it for screening. But it is a good triage tool. So the Q-SOFA or quick SOFA is very simple. It has 3 components: the mental status, which is captured by the Glasgow Coma Scale, being less than 15, so just being abnormal; the systolic blood pressure being less than 100, and the respiratory rate being more than 22. So each of these components, you either have it or you don't, so you're scored 0 or 1. And so your total score is between 0 and 3. Now, of patients with infections, if you have a score of 2 or 3, that is a group that is more likely to end up in the ICU or to die. So only a quarter of patients with infections will have a Q-SOFA score of 2 or more. But that group accounts for 75% of the deaths. So the way that it's intended to be used, first off, is in the hospital setting, not as much in the ER setting. But when you identify these patients that you think might have sepsis, and you can do this Q-SOFA score, and if they are 2 or 3, they have a much higher likelihood of eventually needing ICU care or potentially dying. Okay, it doesn't mean all of them, it doesn't mean that 75% of them die. It just means that this captures the group of people that are very sick. So it's useful. In summary here, sepsis is a life-threatening organ dysfunction, and it is caused by a dysregulated host response to infection. The more recent definitions, we assess organ dysfunction using SOFA score. There is more recently this Q-SOFA or quick SOFA that is a triage tool. And screening tools are lacking. I didn't talk too much about it. Historically, we have used the SIRS criteria to screen. More and more, our electronic health records are actually starting to do this for us. And so, we have our electronic health record, I think, is epic. There are many other ones. But a lot of them are integrating the patient data, and they are using machine learning and artificial intelligence to try and identify those patients that may be at risk for deterioration. These systems are not really ready for prime time, and they can be a little bit amusing. But probably the future will be, in something like that is my guess, to get better sensitivity and specificity. Okay, so pathophysiology, I did put a little comment in here, and I'm a little bit pessimistic because the reality is that even though we have learned a lot about pathophysiology and sepsis, all the targeted treatments that the sepsis community, research community has tried over the years have not demonstrated any consistent benefit. So really, it's a lot of supportive care, even though we know a lot about sepsis. The cascade of pathology, we start with an insult infection, and we have this dysregulation of both pro-inflammatory responses and anti-inflammatory responses, and they spread from the local infection to the whole body. There is injury to the cells, there is ischemia to the organs, hypotension affects all of the organ systems, and this becomes a vicious cycle that may lead to death. Initially, it was thought that, this is mainly a pro-inflammatory process, but it really is both and simultaneously. So pro and anti-inflammatory. So there is pathogens that trigger activation of the white blood cells, activation of the complement system, coagulation system activation, and eventually cell death. But at the same time, there is stimulation of the anti-inflammatory pathways, and this will lead to inhibition of pro-inflammatory cytokines, impaired function of various immune cells, and inhibition of the pro-inflammatory gene transcriptome. And it's well established that if you recover from a severe infection with sepsis, you are at increased risk for developing another infection, and that is probably because your immune system has been downregulated significantly. We'll go now into the specific organ systems, and these are just a brief overview. Each of these could be looked at in much more detail, but in general, cardiac disease and sepsis, the cardiac output is increased, but the cardiac muscle function is less efficient. So if you look at post-mortem exams, there is very little cardiomyocyte death, but a lot of them are injured. And so it's a common thing that we will measure troponin in patients with septic shock, and it may be a little bit elevated. It does not mean that they have, usually it does not mean that they have a myocardial infarction in the traditional sense of a plaque rupture or something like that, but more that there is cardiomyocyte injury. And this is actually thought to be recoverable. So the details here are not super important. We have 3 slides, E, F, and G. So this slide here is the normal cardiomyocyte function here. And you do not need to be a pathologist to note that the septic cardiomyocytes are fairly significantly injured. And this slide here is pointing out some of the mitochondrial damage. And that is a theme that is seen in sepsis, is that the mitochondria are damaged and the utilization of oxygen is impaired. In fact, many tissues get supplied more oxygen than they would in the baseline healthy state, but they are unable to utilize it efficiently. Now, there are some organs, because of microcirculatory changes, that are not supplied enough blood and enough oxygen, but even the organs that are supplied with a good amount of oxygen are not able to use it as efficiently. Hypotension in sepsis, so it's a combination of pathogen and host factors. For example, if you give endotoxin in high enough concentrations to a healthy person, it will induce shock. The capillaries themselves can be damaged and they lead to fluid leak. And when you get enough fluid leak and edema, this will compress the other vasculature and lead to compromised microcirculation. This resultant ischemia leads to the release of vasoactive mediators and general vasodilation, which adds extra stress on the heart to increase cardiac output. And so there is kind of a vicious cycle with sepsis and hypotension. The coagulation system is an area that had been an area of very extensive research. It's been well known that there is an activation of the coagulation system. Tissue factor is expressed, which leads to the generation of thrombin. The anticoagulation pathways are inhibited, and then clot formation is encouraged because fibrinolysis is inhibited. But eventually, when factors are exhausted, then there is more fibrinolysis. Many small clots can contribute to ischemia, and in the final kind of pathway, you can develop disseminated intravascular coagulation. This slide here, it illustrates a lot of the players in septic shock. And again, the details are probably not as important, and I say that because the treatments that we have developed to look at each of these areas have not really worked. But this does happen in sepsis. So let's kind of go over it in brief detail. So there is increased coagulation, expression of tissue factor, and there is decreased inhibitor of tissue factor, decreased antithrombin, and this basically helps lead towards increased thrombosis. There is loss of barrier function in the capillaries, and then you get leakage of fluid, which further compresses the capillaries. The tissue is hypoperfused, and the mitochondria are not working very well, so you get decreased tissue oxygenation. Now, as it specifically relates to the coagulation abnormalities in sepsis, one of the targets, and this was a very promising target, is this activated protein C. And this molecule was discovered actually at the Oklahoma Medical Research Foundation, which is across the street from us. And there was an initial big push to study this in sepsis, the role in sepsis, and it led to the development of a drug. The brand name was Zygris, activated protein C. Initially, it showed some benefit in severe sepsis, and it was put on market, and then subsequently was shown not to have benefit and removed from the market, which is unfortunately how a lot of the specific disease modifying pathways that have been targeted in sepsis, the outcome has been that they have not been shown to be effective broadly. All right, changing gears to the lungs. And again, the theme is that you have cellular injury, you have capillary, microcirculatory injury, and this leads to organ failure. So in the lungs, diffuse alveolar damage develops, interstitial edema develops, and the development of the acute respiratory distress syndrome is common, ARDS. This is just a pictorial. This is nice, normal lung, large alveoli here. And in this slide, you can see thickened membranes. You can see blood has leaked into the alveolar spaces because there is capillary leak. And so in general, this is just part of what can happen when you have severe sepsis affecting the lungs. The kidneys, usually it's acute tubular injury, and the terminology used to be acute tubular necrosis, but more and more people recognize that necrosis or cell death is less common than injury. So the movement has been towards describing this as injury. The blood flow to the kidneys is actually usually preserved, but the metabolism is very inefficient. And with all of the injury that occurs, the phenomenon that a lot of these cells hibernate. They're not as active. On autopsy studies, there is maybe less than 5% tubular cell death. And it is thought that the injury is largely reversible, but it can take a long time, 3 months or more, for a lot of this stuff to be reversible. During COVID, we had patients that were admitted to our hospital for very, very long periods of time. And I can distinctly remember several patients that we had that developed renal failure, requiring dialysis, not making any urine at all. And, 2-3 months later, normal kidney function, normal creatinine. And usually we would be sending these patients out of our hospital well before this would happen. But because of difficulties with the system, a lot of them are staying much, much longer than they otherwise would be. And you could see some of this recovered, which was nice to see. We put people on dialysis and then we don't get to see them get better. So that's nice. Okay, and again, a couple of slides. The details are not as important, but on the leftmost slide, you have normal proximal convoluted tubule, and in the middle and the right slides, you have septic kidney with epithelial damage and dilated lysozymes. And then on the far right, there is loss of this brush border, and the mitochondria are swollen. And this is a theme, is that the mitochondria are particularly vulnerable. GI disease or gastrointestinal disease, there is a loss of barrier function in sepsis, and there can be transient translocation of bacteria. Indeed, the intestinal permeability, the degree of this is correlated with mortality. There are studies that show that, they can measure this by giving patients lactulose and mannitol, and they can see that those patients that have increased permeability, this is correlated with increased mortality. The liver is not usually as much of an issue, but there is decreased blood flow, there is impaired clearance of toxin and impaired metabolism. The central nervous system disease and sepsis. So confusion is very common, and it is out of proportion usually to the degree of hypotension. I'm sure you've all seen patients that have hypotension from other etiologies, and oftentimes it takes pretty severe hypotension for the mental status to be affected. But in sepsis, it starts earlier. The etiology is thought, again, the same mechanisms: cell injury, microcirculatory dysfunction, increased permeability of the blood-brain barrier. And we have some animal models over the years that people have looked at, including rat models where they inject lipopolysaccharide. And this shows that there is an increase in blood flow, but there are areas within the brain, regional areas, that have decreased blood flow, consistent with this microcirculatory dysfunction. So in summary, you have simultaneous pro-inflammatory and anti-inflammatory cascades. There is damage of the vasculature that leads to fluid leak. The microcirculation is impaired. The coagulation system is activated and then inactivated. The mitochondrial damage leads to poor utilization of oxygen, and much of the injury is thought to be reversible if the patient survives. Management. So again, most targeted treatments for sepsis have failed to show consistent benefit. The mainstays are early recognition, rapid response to patient changes, and appropriate fluid and antibiotics. And I put appropriate in quotation marks because we still don't know what appropriate fluids are, and generalized supportive care. So there is a little bit of history here, and I'm a little cynical. I'll preface it there. But the Surviving Sepsis campaign is kind of the international body that provides a lot of these recommendations. And I mentioned to you before that activated protein C was looked at in the 90s as a treatment for sepsis, and it was initially approved. And Eli Lilly was developing this, the pharmaceutical company. And when it got approved, they helped fund this Surviving Sepsis campaign. And so if you're kind of cynical, and a lot of people talk about this, but this was partially as a marketing tool to increase recognition of sepsis, to kind of push for more sales of activated protein C, which was a very hot topic at the time. Anyway, subsequently, Xigris was shown to not be very effective. It was removed from the market. And the Surviving Sepsis campaign had multiple different funding sources, and it was very independent. And it is generally considered the leading body on giving recommendations for evaluation and management of sepsis. But it does have this history, which I think is interesting, at least. So there is also a reaction there is a history of overreaction to the results of smaller studies, and this is particularly embarrassing in our field with regard to fluids, and I'm going to go over that in a little bit of detail. I think that the most recent guidelines, they've done a really good job of being more objective and measured. And, you know, as with all guidelines these days, they're listed as strong or weak, and strong recommendations are intended that most patients should receive the course of action, and you can use it to judge how well you're doing as a hospital. Weak recommendations, there's a little bit more of a one-on-one. Your patient may or may not benefit, and you can kind of choose. And then there were no recommendation statements made, which include, you know, there's not enough evidence to make a recommendation on this issue. Okay. And then when you look at the grading system, so there is a hierarchy of evidence from high quality, moderate, low, and very low quality of evidence. And then there are best practice statements that are just expert opinion. Right? And I'll point out the limitations already. So there are 93 statements made in the 2021 guidelines. Only 15 of them are strong recommendations. The majority of them are weak recommendations, 54. And then there are, you know, 9 statements of no recommendation and 15 best practice or expert opinion statements. Now, underpinning that, this is where it gets, again, a little bit more embarrassing for us in our field, is that only 3 statements are based on high quality evidence. 22 are based on moderate quality evidence, 29 on low quality, and 21 on very low quality evidence. And what this demonstrates, as everybody knows, is that it is very difficult to perform research studies on patients in sepsis and septic shock. You have to have a lot of infrastructure to recruit these patients in a timely fashion and then randomize them to one treatment or another. And so it is difficult in this field to perform research, but objectively, if you compare research in sepsis and septic shock to other fields, we have a less well-developed base in terms of clinical research. And so a lot of our statements are based on kind of moderate quality evidence. So let's focus in on volume resuscitation. All of us know that most patients with sepsis need fluids, and probably a lot of them. So how much should we give, though? The reality is we don't know. The Surviving Sepsis campaign suggests at least 30 milliliters per kilogram of a crystalloid solution like normal saline or lactated ringers or something like that within 3 hours of recognition of septic shock. But that recommendation has some history. So, and this goes back to 2001. there was as a landmark paper, Manny Rivers designed a trial that looked at if we can protocolize supportive care for septic patients. And the goal is that, you know, as a physiologist, we're going to try to increase oxygen delivery to the tissues. So we're going to give fluids, pressors, inotropes, blood products, measure the central venous pressure, the mean arterial pressure, the central venous oxygenation, and we're going to come up with a kind of an algorithm to give all of these supportive care in a way to maximize oxygen delivery, and that hopefully will make a difference. And in his trial, it showed a big difference. So mortality went from 46.5% to 30% between the groups. And so this was a real big deal. And there was a lot of criticism of this, though, because it was thought that a lot of the interventions were unnecessary, the blood products, the use of central venous oxygenation was probably not needed. And so there was questions about how many fluids we should really give people. But based on this result, there were recommendations issued to change practice and to promote these ideas. So even though this was one trial, there were 260 patients. This was such a big result that everyone got very excited. However, these findings were challenged in 3 subsequent well-designed trials across multiple continents. And as you'll see, they were all basically early goal-directed therapy was disproven. So the PROMISE trial in England had 1,200 patients. The PROCESS trial in the United States had 1,300 patients. And the ARISE trial in Australia and Asia had 1,600 patients. And they looked at doing these goal-directed therapies to try and optimize oxygen delivery in a protocolized manner compared to usual care or protocolized standard care, and they found no difference in mortality. So this was a big kind of disproving of early goal-directed therapy. But the problem is that in the time period from the Rivers trial to these trial, the standard of care kind of changed. So everyone became more aggressive with early fluids, and even in these trials, the fluids before randomization, people got a larger amount than back in the Rivers trial. So the standard of care changed. And based on this kind of circular logic, the Surviving Sepsis campaign said, well, let's give at least 30 mils per kg in the first 3 hours, but we're going to recognize that this is not a strong recommendation, this is a weak recommendation. And that's because the data is not there. However, the practice habits have changed in between these trials, so it's difficult to say what the fluids should be. And of course, all of us in the field know that some people need much more than this. So the way forward is maybe we should do an individualized approach. Should we use dynamic measures to predict fluid responsiveness? And there are many ways to do that. I've put in probably the best and simplest way, which is looking at what happens with the passive leg raise. So, you know, you have your patient sitting with their head up, and then you put their head down and their legs up. And ideally, you are measuring a change in cardiac output or a surrogate of cardiac output. And that will help predict if the fluid responsiveness will occur. If there's an increase in cardiac output of more than 10%, then probably they will do well with extra fluids. More and more, we move towards non-invasive measures like point-of-care ultrasound. And for example, I show here that, you know, this is an ultrasound image of the left ventricle, and this is in diastole, and this is in systole. And you can see that the chamber has, you know, fluid here, and then when in systole, It is completely obliterated. We call this the kissing of the walls. And so this is a hyperdynamic heart, probably one that needs more fluid. The bottom two parts here, this is the inferior vena cava in M mode, and then this is another view of the inferior vena cava. You can see it's very collapsed, so you would think maybe this patient should get some more fluids. And I say this with caution because in our field we have embarrassing history of overreacting. I will emphasize that there have been a few small randomized clinical trials looking at the use of point-of-care ultrasound and does it impact outcomes? And so far the answer is no. So far the answer is that using this stuff does not make your patients more likely to survive. I will say that there's a lot of us that are skeptical and think that the trials have not been well designed. And it is certainly the hot thing is to use point-of-care ultrasound in all of our patients. I have attached here a useful resource from the American Thoracic Society. It is developed for residents and medical students about ultrasound use in the ICU, and it's really fantastic as a resource to use. We have a pretty extensive ultrasound, point-of-care ultrasound training as part of our fellowship, and you know, even though the data is not there yet, I think a lot of us think that it will be over time. Okay, so back to the surviving sepsis guidelines and the emphasis. There has been an effort to replicate this golden hour that is famous from trauma. I think everybody agrees that even though we're not sure how many fluids or antibiotics or whatever, time is important, and recognition and early treatment is probably important. So while there is not a great evidence base still for this golden hour, it is still something that we are trying to emphasize early recognition and early responsiveness. So the aspirational goals are when you see somebody you think may have sepsis, measure a lactate level immediately and repeat it if it's more than 2, obtain blood cultures, and initiate appropriate broad spectrum antibiotics. And there is a question about, I'll get to that in a second. Also give fluids if the patient is hypotensive or if the lactate is greater than or equal to 4. And begin vasopressor therapy if they're not responding to fluids, with the goal of maintaining pressure, mean arterial pressure more than 65. In terms of antibiotics, the guidance is simple and practical. So you have 2 categories: shock is present or shock is absent. And then the other 2 here are sepsis is definitely happening or probably happening, and sepsis is just possible. So it's very practical. If your patient is in shock, you give them antibiotics promptly if they have an infection or if it's even a possibility. And the idea is that the risk of not giving them is significant. If you do not have shock, then if they do have an infection and sepsis, give it to them quickly. But if sepsis is just a possibility and it's not in shock, you have time. You can look for other etiologies and maybe give antibiotics within 3 hours. That's the recommendation. Okay, so these are practical. I like these guidance. The choice of fluids, crystalloids are the first line choice with a strong recommendation. And usually that's normal saline, but there is a weak recommendation that balanced crystalloids like lactated ringers or Normasol or Plasmolite or whatever version you have. These are suggested, and they may help prevent some of the hyperchloremic metabolic acidosis that we see with a vigorous fluid resuscitation in the ICU. And then albumin is suggested if you have a large volume of crystalloids as a way to increase the circulating blood volume without giving as much saline. This is, again, a weak recommendation, has limited use. Vasopressors and inotropes, these are just a very brief overview. The goal is to maintain a mean arterial pressure more than 65. And pretty much for all of our patients, norepinephrine will be the first line choice. We dose this based on body weight, 0.05, 0.5 mics per kg per minute. There really is no maximal dose, but our protocols stop at 0.5. Vasopressin we add to norepinephrine generally when the dose is 0.2 or more. Vasopressin is expensive, so we don't use it routinely, just when we have 0.2 or more of norepi. And it is a fixed dose. We do it at 0.03 units per minute. You can also do it at 0.04 units per minute. We do it at the lower rate because that was studied as adequate, and it is 25% cheaper. So that's the initial two that we use. Epinephrine is suggested to be used as a second-line agent. But keep in mind that epinephrine will cause an increase in lactic acid production at higher doses. So if you're following lactic acid levels, they may be less accurate. And then dobutamine is suggested if there is a concern for suboptimal cardiac function as a part of your septic patient. This is a weak recommendation, very individualized. This is where we use point-of-care ultrasound to look at the left ventricle. In practice, we run this at a fixed rate of 5 and rarely go beyond that, just because there's all the problems with arrhythmias and things at higher doses that we prefer to avoid. So in summary, early treatment of sepsis is encouraged. The evidence base is somewhat lacking, so there's a big need for good clinical trials. The mortality is probably decreasing some with time, and I think we're moving towards an individualized approach. I'll put a general comment that I think that the conceptual frameworks for sepsis are probably holding us back at this point. There is some new trends towards trying to sub-phenotype sepsis in terms of an inflammatory kind of an anti-inflammatory sepsis. I think we're looking at a syndrome in too broad of a picture, and we probably need to focus on smaller pieces to develop therapies. But we'll see where the future goes. So with that, I'm open for questions. Thank you for letting me speak.
May I ask a question, please?
Yeah, of course.
Thank you, Professor Pshebinda. It was very interesting. And my question is about the amount of fluid. You mentioned about individualized approach to patients, and you mentioned that the amount of fluid should be at least 30 milliliter per kilogram weight. But what about patients, elderly patients, or patients with severe comorbidities?
Yeah, and I think with the new updates, it is recognized that you may need to be a little bit more careful. Now, the recommendation is for 30 milliliters per kilogram within the first 3 hours as kind of a minimum. And most patients probably will benefit from that, is the expert guidance, I guess, but the evidence base is not very strong. And the guidelines, I think, now allow us to be a little bit more cautious in terms of fluids. So you're absolutely right. The elderly patients already on oxygen with pre-existing heart failure, we may elect to be more conservative. The counter argument to that is, even a patient in heart failure, if they develop sepsis, they may need fluids. So I think that the individualized approach, we try to use point of care ultrasound. We try and look at diastology and predict if we may get some, benefit from fluids. And these other things like doing the straight leg raise test can be helpful when we're making decisions about fluids. So I don't have a great answer for you, but I think you're right. We can probably do less in some of our patients.
Thank you.
Dr. Pshebinda, it was so interesting lecture. Thank you for this. Especially, I appreciate you from new materials. No, I mean, I appreciate you from analyze of new material and to improve our understanding of our students. I have 3 questions. At the first, is it correct if I understood? You told that distributive shock is most popular from all of types of shock. And what does you mean? What do you mean?
So in the ICU, I mean, we teach our residents that when they're in the medical ICU and they see a patient in shock, probably 3/4 of the time it's distributive shock. And of that, 90% of it, it's septic shock. So if you just play the numbers, most likely that's what's going on. But you still need to obviously look at cardiac output. Is there cardiogenic shock? You obviously need to look for any signs of bleeding, and you need to do a thorough evaluation. But in general, when you look at all comers in our medical ICUs, typically distributive septic shock is going to be the most common etiology. That's all I know.
Yes. No. So if I understand, in USA you have intensive unit care that take about difficult patients. Yes, in difficult situations, and emergency department that take care patient with hypovolemic shock. Yes. So that's why, especially distributive. Yeah. Is it correct?
Probably,
yeah.
Okay. We are separate from the ER. The ER, I guess, may have a little bit different numbers.
Okay, thank you. And next, my question. Unfortunately, we don't have high-level amount of hemodialysis tools in our intensive care units. It's so expensive, and we of course try to do it, but I'm sorry, but no. And of course we don't have enough experience treatment patient with sepsis, septic shock, and long treatment. Most common out treatment who has acute renal failure will die. Yes. So is it correct if I understood that you provide the patient with renal failure due to sepsis? You could provide long-term dialysis, and some months it could be, yes. And finally, you have recovery of tissue of the kidneys.
Yeah. So yes, we have. So even patients that are in septic shock that require dialysis, we will then, if they recover enough, we'll put in a tunneled dialysis, line, and they will leave and they'll go to like a long-term care facility typically, and they will get dialysis. But it is not uncommon for the kidney function to recover. but it takes a long time. So when we see him in the hospital, you know, it looks bad, but the kidney doctors, you know, when they see them later, they say, yeah, a lot of them will recover, but it can take months. But yes, that's correct.
Oh, thank you. And last question, patient with sepsis and with gastrointestinal disease. Yes, it's so difficult category of patient. What is your approach for treatment in these situations?
Can you be more specific in terms of what kind of gastrointestinal disease? Do you mean like bleeding or?
No. I mean, when we have a leakage, yes, and
Location? Yeah.
translocation, yes.
I mean, I think broad spectrum antibiotics, we do a little bit of, you know, low level feeding, trophic feeding, we call it, like 10 cc's an hour, something like that, of food to try and encourage the maintenance of the bowel lining. Whether or not that works, I don't really know, and we don't really do it if the vasopressors are higher than, you know, 0.2 mics per kg per minute of norepinephrine. But up to a moderate dose, we will do a little bit of enteral tube feeds. I don't think there's a good, you know, but I don't think that really does much. I think we're stuck in the same boat as you. When these patients get that sick, they're, you know, oftentimes they just die. So.
Yeah, yes. Oh, okay, thank you. It was so interesting. Thank you. Thanks a lot. Maybe
Thank
somebody wants to ask something to Dr. Pshebinda. No, any more questions?
Thank you again.
Yeah?
I very much appreciate you letting me lecture. Happy to do so in the future if you so desire. Again, you know, thoughts and prayers for you. I cannot imagine how difficult